All right, so welcome and good evening, everyone. My name is Apu and I'm the Injury Prevention Officer here at Injury Matters. I'm so excited to be facilitating this webinar today, which will be looking at foot health and its impact on falls in older adults. I'm also joined today by Dr. Chern representing Podiatry WA, along with our speakers for today, Morton from Diabetes WA and Deborah Chern from Chern Podiatry. I'd like to thank everyone for tuning in today and taking the time out of your busy schedules to build your knowledge and awareness around falls prevention. Today, I'm facilitating this webinar from Whadjuk Noongar land. So I'd like to acknowledge the Whadjuk Noongar people as the traditional custodians of the land on which I am facilitating this webinar today. And I also want to pay my respects to their elders, past and present, as well as the leaders emerging. Australia always was and always will be Aboriginal land. I'd love to know where all of you are tuning in from today, so please feel free to use the chat box to acknowledge the traditional custodians of the land you are tuning in from today. Before we start, I want to go over a few housekeeping points. Can everyone please double check that the microphones are muted and remain muted till the webinar ends and the Q&A starts. It just helps with clarity when the presenters are speaking. We'd also love to hear your questions, so feel free to use the Q&A box to pop in any questions for Q&A time at the end. We'd also just wanted to know that the webinar is recorded, so and yeah, you'll get the recording after this webinar concludes, as well as if you have any other people tuning into the webinar today with you, we'd appreciate it if you could please send us a quick private message just to help us know how many people are tuning in with you during this webinar. So a bit about Injury Matters. We are for safer people and places. Injury Matters aims to prevent and reduce the impact of injury within the Western Australian community. We do this through advocating and providing education for injury prevention, as well as providing support for people who have been impacted by injury. Today's workshop is brought to you through our Stay on Your Feet program with the support of the Department of Health WA. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults and how to prevent falls in the community. This is done through the Move, Improve, Remove campaigns, which are namely Move Your Body, Improve Your Health and Remove Hazards. So before I welcome our first speaker for tonight, let's have a look at falls in WA. Each year, 1 in 3 people over the age of 65 experience a fall. This becomes 1 in 2 people over the age of 80. On average, a Western Australian dies from a fall every 26 hours, is admitted to hospital for a falls-related injury every 19 minutes, attends an emergency department as the result of a fall every 12 minutes. So as you can tell, falls are a serious public health concern in WA. Older adults are at a higher risk of foot-related health problems that increase their risk of falling, as feet are directly linked to an older adult's posture, stability, balance, and walking pattern, influencing the risk of falls. A diagnosis of diabetes is a big risk factor to foot health, with studies also linking peripheral neuropathy and falls. To further elaborate on diabetes and its impact on foot health in older adults, I would like to introduce our first speaker, Morton, who is a diabetes educator at Diabetes WA. So I'll just hand it over to Christine.
Good evening, everyone. I'll just share my screen. Can you all see the screen?
Yep, I can see your slides, yep.
Excellent. Thank you, Apu, for the introduction. Yes, I'm Christine. I'm from Diabetes WA, and I'm here this evening to speak to everyone about diabetes and the impact diabetes has on foot health. In tonight's presentation, I'll be speaking about what is diabetes-related foot disease, which I will refer to as diabetes foot disease, the incidence and impact of diabetes foot disease. We will also explore how diabetes affects the feet, looking specifically at peripheral artery disease, and I will briefly speak about peripheral neuropathy and loss of protective sensation. However, Deborah, Chern, who's speaking later, will give us a lot more information around this. We will look at steps at preventing diabetes foot disease. I'll also speak a bit about stratification to identify those who are at risk of developing diabetes foot disease, and also referral pathways for those people who've already developed active foot disease. I'll speak briefly about Diabetes WA and the self-management education programs that we run to assist those people living with diabetes to achieve good self-management outcomes. And I'll also provide you some with available resources that you can look at in your own time if you have a special interest in this area. And then I'll finish off with a couple of key messages. So what exactly is diabetes-related foot disease? Diabetes Feet Australia have defined diabetes-related foot disease as foot ulceration, infection, or tissue destruction in people with diabetes, accompanied by the risk factors of peripheral neuropathy and or peripheral artery disease. So in a nutshell, anybody who is living with diabetes who presents with a foot ulcer, infection in either the soft tissues or the bones of the feet, and has an underlying peripheral neuropathy or peripheral artery disease, basically presents with diabetes foot disease. So let's look at the incidence of diabetes foot disease. Australia has the second highest rate of diabetes-related amputations in the developed world. And as a result, diabetes foot disease has been tagged as Australia's least known major health problem. Approximately 50,000 Australians are affected by diabetes foot disease every year. And in addition to that, another 300,000 people living with diabetes are actually at risk of developing diabetes foot disease. In a year, around about 2% of Australians will develop diabetes foot disease. And somebody who's already developed a diabetic foot ulcer has a 40% chance of re-ulcerating again within 12 months, and a 65% chance of re-ulcerating again within the next 3 years. Unfortunately, Indigenous Australians and people living in remote and rural areas are also at greater risk of developing diabetes foot disease. So let's look a bit at the impact. The impact of diabetes foot disease is far-reaching. In Australia, diabetes complications result in 28 hospital admissions per day and in 12 amputations per day. So this would equate to about an amputation every 2 hours, or 4,400 amputations per year. This places a significant burden on the individual, the community, disability services, our societies, and our healthcare system. And then we're not even talking about the overall economic impact on our health budget, because it doesn't stop with that one incidence of that amputation. As we've mentioned before, people who've previously had a diabetes foot ulcer and it could have led to an amputation still have that risk of re-ulcerating, a 40% chance of re-ulcerating within 12 months or 65 in 3 years. So it's an ongoing concern and ongoing cost to our health budget. But the good thing is it's not all doom and gloom, as almost all diabetes-related amputations can be prevented by early detection and treatment. And I'll speak a little bit more specifically about this later. But first, I thought we should probably have a look at what actually happens with diabetes and our feet. So how does diabetes affect our feet? Well, the metabolic nature of diabetes, and also linked in with the elevated glucose levels in the bloodstream due to the diabetes, places an individual at greater risk of developing peripheral artery disease and peripheral neuropathy. And these conditions can occur independently of one another, but they often occur concurrently in people living with diabetes. So let's start by exploring how diabetes affects our arteries and how this leads to peripheral artery disease. Peripheral artery disease occurs when there's a reduction in blood flow as a result of a narrowing in the artery. And if you look at the top picture, you can actually see that quite clearly, the narrowing that occurs there. And this is due to atherosclerotic changes and plaque that builds up within the artery. All arteries can be affected in diabetes, and we commonly see it in our our coronary arteries, and occurs very commonly in our arteries supplying our extremities, like our femoral artery, popliteal, and tibial arteries. And when the blood glucose levels are elevated for an extended period of time, what actually happens is the artery walls become inflamed. And this inflammation that occurs actually accelerates the buildup of that plaque. And of course, that results in more plaque building up. It reduces the lumen of the artery. And as a result, there's less blood flow to the areas distal to that blockage or that narrowing. As a result, oxygen, blood, nutrients are all reduced to that area. And tissue deterioration then occurs, as well as muscle wasting. So if you have a look at the picture on the bottom screen, you can see the picture of the foot, and at first glance, it might not look too bad. But if you actually look a bit closer, you can see that the tendons are very pronounced. And that's an indication to us that there's been tissue loss and muscle wasting in that foot. And muscle wasting is something we see throughout the body with diabetes, unfortunately, as a result of those metabolic changes that occur. Naturally, if there's less blood supply, wound healing, if there's any injuries to the foot, would be delayed. Oxygen, lymphocytes, antibiotics really take a lot longer to get to that area because of the reduced blood flow. And in some situations, before an ulcer or a foot wound can actually heal, revascularization procedures such as angioplasty or stenting and bypass might actually be required to facilitate the healing of that area or that wound. We also observe that there could be a decrease in blood supply to the nerves, and that contributes to some of the peripheral neuropathy or the loss of protective sensation. Okay. But it's not only the decreased blood supply to the nerve that will result in the peripheral neuropathy. Just as our blood glucose levels, high blood glucose levels result in inflammation of the arteries, our nerves don't like to be bathed in glucose either. And prolonged periods of high blood glucose cause damage to the myelin sheath of our nerves. And this actually affects the ability to conduct the impulses. The effect of this is a bit like a damaged electrical cord. So while the damaged electrical cord can still conduct electricity, it might spark off in places. And that's pretty much what happens as well when our nerves become damaged. And that sparking off effect is what could possibly be felt when people develop symptoms of paresthesia, like the tingling, the pins and needles feeling. And those symptoms can actually progress to pain and numbness and loss of the protective sensation within our feet. So if somebody has already experienced that loss of sensation in their feet, they may not be aware if they've actually sustained any trauma to their feet, things like blisters from shoes or any cuts, burns, or ulcers. They might not actually be able to feel, and therefore they probably not even aware that they're there, not taking care of them. And that can lead to quite nasty infections like cellulitis, osteomyelitis. Unfortunately, gangrene is not uncommon, and that's the causative organism usually that will lead to an amputation as well. The neuropathy related to diabetes is usually bilateral, so it's experienced in both feet more or less simultaneously. But it can occur in the hands as well, although that's not nearly as common. We tend with diabetes to see it a lot more occurring in the feet. And we also talk about the neuropathy as being a sock and glove presentation. So what that really means is it starts off at the tip of the toes and it moves up the foot and up the leg, a little bit like putting on a pair of socks. You start at the toe and you'll pull it up further. And it's generally bilateral, so the level is pretty much the same in both legs. Some people will also develop quite marked neuropathic pain, and they may require medication to actually manage that pain. And in severe cases, there can be deformities that can occur as a result. Something like Charcot's neuropathy or Charcot's foot can also occur. But I'm going to leave further discussion of the impact of neuropathy for Deborah Chern, and she'll be speaking to us in depth about this a little bit later. So let's talk about preventing diabetes foot disease. As I mentioned earlier, most diabetes-related amputations can be prevented, and up to 85% can be prevented with early detection, timely referrals, and appropriate management. Prevention starts with a person living with diabetes and them being empowered to effectively self-manage their diabetes, perform daily foot care, and self-identify any foot problems. In addition to this, by self-managing their diabetes, they also need their team around them. And this includes regular visits with their GP and also assuring that they attend their pathology investigations as prescribed by their GP, because this allows them to actually monitor how their diabetes is going. Every person in Australia living with diabetes should also have a GP management plan or a care plan to assist with them accessing the necessary allied health care that they would require as people living with diabetes. And that would include podiatry, maybe dietetic services, maybe diabetes education, among others as well. And we also recommend that a full neurovascular assessment be performed at least once a year, and that is preferably performed by a podiatrist. And the podiatrist will perform these screenings as per the person's risk category. One of the most important things that leads to diabetic foot disease or active foot disease not being treated effectively is that timely referrals don't occur. And a timely referral to a multidisciplinary foot care team, as per the active foot disease pathway, which I'll speak a bit about later, is essential to preventing amputations with those people living with diabetes and foot pathology. Okay, so what are our roles? Every health professional has a role to play in preventing diabetes foot disease, whether you're a support worker assisting with activities of daily living, or a practice nurse doing dressings, a diabetes educator, a GP or a specialist. Every single healthcare worker is in a position to prevent diabetes foot disease. So when we're talking about that, what conversations should we really be having with our clients? So as I mentioned earlier, it all starts with good diabetes management. And that the person who's best at managing their diabetes is the person who's living with diabetes. And we know that somebody who's had diabetes for a long time is at higher risk of developing diabetes foot disease. But then people who with poorly managed diabetes and very elevated blood glucose over a period of time are also at high risk, regardless of how long they've been living with diabetes. So we need to encourage our patients to achieve and maintain their blood glucose targets, and therefore it's important that we know what those targets are to recommend. So we generally recommend an HbA1c, which is a 3-monthly blood test that gets done at the pathology lab, and it gives us an idea of what's been happening in that period. We recommend that the HbA1c should come in at under 7% for people under the age of 75, and for people over 75 at 7.5%. However, some patients may have a more individualized HbA1c target, and this will be based on their overall health presentation and also their risk of hypoglycemia, which of course can also lead to falls. We do recommend that people living with diabetes, and particularly those at risk of developing foot disease, check their own blood glucose levels by self-monitoring at home. And their target ranges that they should be looking for when checking at home: a fasting reading in the morning, we recommend under 7 millimoles per litre, and a reading 2 hours after a meal, we would recommend under 10 millimoles per litre. Just interesting to note that that 2 hours after the meal actually starts when they start eating, not once they've finished the meal. So if they are going to be checking afterwards, yeah, pretty much from the time they start eating, time 2 hours, and then check their blood glucose again. Achieving and maintaining blood glucose to target is not always easy. And people living with diabetes may be required to make quite a number of changes, particularly maybe dietary changes, or they may be asked to increase their physical activity. They may be required to take additional medication, or even just change their medication taking behavior, because not everybody likes taking medication, and they might need some guidance and some support with regards to taking their medications regularly. And it's also important that they have regular reviews with their diabetes team. And their diabetes team could be quite a broad team. It could include their GP, their podiatrist, their dietitian, an exercise physiologist. And one that we often forget as part of our team is the pharmacist, where they get their medications from, and a diabetes educator. And all members of their team could actually be involved in supporting them to achieve their better self-management outcomes. So it doesn't matter how long somebody's been living with diabetes, it's never too early to start a conversation about diabetes and foot health. And when engaging in a conversation about foot health, it's possibly easiest to start with the 5 steps to healthy feet. And those would be step 1, caring for our feet. Step 2, checking our feet for changes and problems. Step 3, protecting our feet. Step 4, stopping smoking. And step 5, having our feet checked by a health professional. So let's explore this a bit further. Step 1 is caring for our feet. So we really need to encourage our clients to wash their feet daily, at least once a day, and to dry their feet with a soft towel, paying particular attention to drying well in between the toes, because that's an area where moisture can build up, and where moisture is, that can lead to fungal infections and bacterial growth, and also skin breakdown, which can be a portal then for infection. And as we get older, our feet tend to get dry as well. So applying some moisturizer to prevent dry, cracked heels or skin along the feet is also important. Moisturizer really prevents that cracking of the feet and those deep fissures that can sometimes be seen to form. Because those fissures can actually split and become a portal for infection as well. One thing to note, if you are encouraging people to apply moisturizer, please remind them to let them absorb the moisturizer properly before they go walking around, because your feet get pretty slippery when you've just applied moisturizer. And we generally recommend to our clients that you actually apply it at night just before you go to bed, so it gives a chance to absorb before you need to get up again. We also recommend that nails should be, I think I'm ahead in a slide here. No, I'm not. We also recommend that nails should be cut weekly. And the way we cut our nails is actually quite important. We should be cutting straight across the top and follow the contour of the nails, and then just filing away any sharp edges. It's not always easy for people to reach down to their feet to actually cut their toenails or do their foot care. And we do recommend that they seek assistance from another family member or from a professional if they are struggling to see or to reach down to attend to their foot care. Okay. So step 2 is checking our feet for changes or problems. So encourage daily foot checks. And this includes looking at the top, sides, soles, heels, and in between the toes of both feet. And this can be tricky, particularly for older adults, because flexibility isn't always there, and it's sometimes really difficult to get down there. So some people might actually be required to use a mirror to see their feet to actually do the checks, or alternatively, they could get a family member to help them to do their daily check. And what they should be looking out for are things like new blisters, any signs of ingrown toenails, any ulceration, any new corns or calluses, any unusual redness or swelling, any cuts and bruises that they weren't aware of, because that could indicate that they've had a trauma that they weren't aware of, or anything that looks different from the previous day when they checked their feet last. And if any of these are noted, they should see their GP or podiatrist urgently. Home remedies and treatments such as using corn plasters or corn planers are not recommended, and we actually tell people to avoid them as best possible. Unfortunately, corn plasters can actually be quite acidic, and they can cause skin breakdown underneath the plaster. Also, we're not always sure what's underneath a corn. There might actually be an ulcer already forming under a corn, so we don't really want to be planing a corn or putting a corn plaster and causing further damage. So it's best to seek professional help in these situations rather than cause any additional trauma. Step 3 is protecting our feet. Shoes are probably the first line of protection that we have from injuries for our feet. And we do recommend that shoes be worn inside and outside of the home. For people with diabetes, we strongly discourage them from walking around bare feet. And this includes being indoors because, trauma happens to our feet inside the house. How often do we stub a toe, drop something on our toes, spill some hot liquid that might land on our feet, drop items that might land on our feet? So trauma inside the home is quite common as well. And as a result, we recommend that you wear shoes inside as well if you have diabetes. When it comes to buying shoes, we also recommend that you have your feet professionally measured to ensure that they fit correctly. And one thing that a lot of people aren't aware of, that as we age, our arches actually sag a little bit. And as a result of this, our feet get a little bit longer and they might also get a little bit wider. And those changes over time can actually result in us requiring a different size shoe. So if you've always worn the same size shoe and all of a sudden you require a bigger one, it's probably just part of the aging process happening. We also recommend wearing socks with shoes. It prevents trauma from chafing, and also socks made from natural fibers actually work to keep our feet dry because they wick moisture away from the skin, and therefore less chance of any bacterial or fungal buildup in that moisture. If you are going to be looking at buying socks, we also recommend socks with a loose cuff for people with diabetes. Any tight elastication around the ankles is not recommended because it can affect that blood flow to the feet again. And probably the most important thing is choosing appropriate shoes. So when somebody says choose an appropriate shoe, what does that actually mean? So we would recommend a shoe that has a nice smooth lining without any internal stitching. And that just prevents any folding inside the lining, rubbing against the shoe or putting any pressure areas. And also stitching inside a shoe can also cause pressure points on the feet. We recommend that it has firm adjustable fastenings such as laces or Velcro, a low heel with a nice firm heel counter, and a nice deep wide toe box so that the feet aren't being having pressure at any point across the toes either. We recommend a non-slip sole and that the uppers are made from a soft, breathable material. Your shoe should be flexible across the toes, but they shouldn't be able to twist from side to side, and that would give maximum support. And just a little tip, always encourage people to check inside their shoes before they put their feet on. If you have somebody who's already lost some sensation, things drop off into our shoes, or maybe little insects or spiders can climb into them. It's always a good idea to just make sure there's nothing inside your shoe and give it a good shake before putting it on in the morning. One that's fairly obvious to most of us, step 4, is to encourage people to stop smoking. And the reason for this is because it really reduces the risk of the further progression of peripheral artery disease. And then number 5 is having your feet checked by a health professional. So a podiatry review is recommended at least every 12 months for people at low risk of developing foot disease, every 6 months for those that are categorized as being at intermediate risk, and every 3 months or more frequently is recommended if they are at high risk of developing diabetes foot disease. During the review, a full neurovascular assessment will be performed, and that will include assessing for any loss of sensation. And the podiatrist normally would use a 10-gram monofilament, which is like a thin, like a little plastic tube, which they touch at various places on the foot to see if the person has sensation in those areas, as well as a vibration test. And that could be done using a charge tuning fork or a fancy little device called a vibratip to feel if there's any vibration being sensed in the foot. Circulation is also assessed by the podiatrist, and they normally start just by feeling the pedal pulses, and then they'll use a Doppler to assess the waveforms and also do an ABI test, which is basically an ankle brachial index. So it really looks at the blood flow to the feet in comparison to the blood flow to the arms. And that is an indication if somebody's presenting with any peripheral artery disease, or it can also indicate if there's a change in that, if there's been progression of existing peripheral artery disease. The podiatrist will then also do a few other assessments, and they'll look for alterations in the foot function. They'll look at changes in somebody's gait and the way they walk. They'll look for any structural abnormalities or deformities, and they'll also advise accordingly with whatever they find to prevent any further loss of function or any further deterioration. Skin care and nail care is also normally performed during one of these podiatry consultations. And once the podiatrist has completed all the assessments that they need to do, they basically determine the person's risk of developing diabetes foot disease using a form of risk stratification. And that allows people to be categorized. And that will guide them with regards to how regularly somebody needs to be rescreened with regards to diabetes foot disease risk. As health professionals, we often tend to shy away from looking at someone's feet. But please don't be afraid to ask somebody to take off their shoes and socks if it's appropriate at that moment. This one activity not only provides the opportunity to start the conversation about the 5 steps towards healthy feet, but it also gives you a very good insight into that person's foot health. And it also gives you an indication if they require any further education, whether they require referral to a specialist unit, if there's further advocacy that's required, or if any intervention is required. So as much as we try not to ask people to take off their shoes and socks, we are missing out on a lot of information by not taking that one small step. So I've mentioned risk stratification and referral pathways. At Diabetes WA, we tend to refer to the one that put forward as put together in association with diabetes, the Diabetes Society of Australia, the NDSS, and Diabetes Australia. And this is a risk stratification tool and a referral pathway for people with active foot disease. As I mentioned, podiatrists use a risk stratification to determine somebody's risk of developing foot disease, and that forms a framework of the frequency of follow-up and screening, and also they may develop a foot action plan based on that. As health professionals, it's important that we're familiar with the risk stratification tool, as this provides us with information regarding follow-up care. And for anybody working in primary healthcare, that can be very useful, having this knowledge to assist you in allocating team care arrangements, consultations for the various allied health providers. Just looking at the risk stratification, if it's somebody with high risk, you know they're going to need a minimum of 4 visits with a podiatrist for the year. So that helps you with those decisions and those conversations that you need to have around splitting up those allied healthcare referrals. The active foot disease pathway also provides a clear and concise guidance with regards to referral to specialist services. And it also facilitates appropriate and timely referrals to these services, which ultimately prevents the amputations. Both of these pathways can be downloaded from the NDSS website, and I would strongly encourage you to have a copy of these on hand. It's a very useful tool to have when you're advocating for a patient, especially somebody who is at high risk or might already have diabetes foot disease, and maybe they haven't been referred on as early as they should. It's a lovely tool for you to use for advocacy for that patient, to have that conversation with other members of their diabetes team. And for for doctors in general practice, it's also a good indicator to know when and how urgently they bring their clients to a high-risk foot service. So definitely worthwhile having on hand in your practice. As I spoke about earlier on, diabetes self-management will always be the first step to preventing diabetes foot disease. If we manage our diabetes well, our risks of developing any of the long-term effects of living with diabetes is reduced. And if you have any clients who require assistance with their diabetes self-management, it's recommended that they be referred to a credentialed diabetes educator. There aren't always enough allied health visits to go around, and there has been evidence that group diabetes self-management programs and online self-management programs have proven to be effective in enhancing diabetes self-management and also improve the long-term health outcomes of people living with diabetes. Diabetes WA offers a suite of free self-management programs under the NDSS for people living with diabetes in WA. And if we have people who've joined us from interstate, your state's diabetes service chapter will also be able to provide the service within the state. At Diabetes WA, we have the Daphne program, and this is tailored for people living with type 1 diabetes. And we also have the Desmond program, the SMARTS program, and an online Desmond program for people living with type 2 diabetes. We also run webinars, and these webinars are for people with diabetes, but we also run webinars for health professionals for upskilling. And we also have a helpline that's available to the public as well as to health professionals, and we welcome calls from health professionals to our helpline. And any other information, you're welcome to visit our website to see what else we offer, and we'd really like you to engage with us regularly. Other available resources, if you'd like some more information with regards to diabetes and foot health, the NDSS has great fact sheets for health professionals on their webpage. So please pop in there. There's a lot of information on different topics, and they extensively cover diabetes and foot disease. Diabetes Feet Australia have a lot of information and also run webinars from time to time that you can join in with and upskill with regards to diabetes and foot health. Foot Forward is available as well as a resource. They have a great screening tool to see how healthy your client's feet are. They also have online modules that you can work through if you would like to. The Australian Podiatry Association has plenty of information. I'm sure Deb will speak a little bit more about that as well to us. And then, of course, Diabetes WA. If you would like to become proficient in conducting foot health assessments, so for those patients, maybe if you're working in a country area or remote or rural area, and you'd like to learn how to actually do a full neurovascular assessment, the Benchmark Group offers a 2-day course in foot health assessment as well. Although there is certain criteria for health professionals of what level you need to be at to actually attend one of these courses. So wrapping up from my side this evening, I'd like to say that my key messages this evening would be is, please remember that most diabetes amputations can be prevented, and they're prevented through good diabetes self-management and appropriate and timely referrals. It's never too late or too early to start a conversation about diabetes and foot health with your clients. Please, when it's appropriate, look at your client's feet when you have that opportunity. They don't always come around that often, especially when we're busy practicing our professions. But if it comes around that opportunity, grab it with open arms. And be familiar with the risk stratification and active disease pathways. It just gives you an idea of those conversations that you might be wanting to have on behalf of your patient. There will be a question and answer session after Deb has spoken to us further about peripheral neuropathy, and please jot down your questions. I'll be happy to answer them afterwards. And thank you for your time this evening, and thank you to Injury Matters for stay on your feet in the Department of Health for allowing me to come and speak to you this evening about diabetes and foot health.
Thank you so much, Christine. That was really engaging and interesting for all of us. So thank you for that. Now, Moving on to peripheral neuropathy and the risk of falls in older adults, I want to introduce Deborah Chern, who is a practicing podiatrist at Chern Podiatry. Deborah, onto your slides.
Excellent. Thanks so much. The only thing is my neighbour's dog is crying next door. So if you hear some howling, she must have been left at home alone. I'm really sorry. So here we go. So feet and falls. Exploring the link between foot health and falls. I was really nervous and thought, I don't know this. I'm no good at this, but then I got on and did some searching, and you know, three of my favorite authors had just published something. So Bolton, Armstrong, and Najal had all just given me some latest evidence. So I felt a little bit more confident. But yeah, exploring the link between foot health and falls, it really is about us, isn't it? It's about the foot. The foot isn't ready to accept weight in the right way. The foot's not in the right position to accept weight. So yeah, we're definitely an intimate part of it. So these were our learning outcomes for today. And I'm pretty sure this, the third one is me, neuropathy and the falls. The Australian Statistic, so this one was from 2019. I think what's important for us is that the falls, most of them are on the same level, okay? So we are talking about feet. And then that the body part that's hurt, it's nearly, you know, 30% is the lower limb. So certainly with the hip and the thigh, we see these people. So we see them post, if they've had a hip fracture or injury, they can't, or a hip replacement, they can't reach down to their feet. They'll be using some aids. So we have a chance to see them then. Knees and legs, definitely. But the foot and ankle injuries being so low at 1.5%, I query that, because I'm wondering whether, you know, when you've got a fractured hip, how much are they actually checking your, if you also sprained your ankle or stretched some perineal. So just being a scientist and wanting to always question the literature, I wonder whether there aren't a whole lot more foot and ankle injuries. Our WA stats, we covered most of these. For me, Apu did, the striking one for me is 28,000 falls attended by the ambulance, St John of God. I wonder, of those 28,000 people, how many did have ambulance cover, or how many got home recovering from their injury and then get the bill in the mail? Because yeah, not everyone does. So that's a significant cost for a lot of people. And then yeah, 42,000, you know, presentations to ED. It's not the most ideal place for presentations. But that's when they happen, so that's where they end up. And just that the Kimberley does have the highest rate of falls in WA, so there might be some social determinants of health involved there. The other important thing I thought was 35% of the falls are on the same level. Okay, so it's that slipping, tripping, stumbling. We're talking about the foot again. The foot either didn't pick up far enough, the foot slipped in poor footwear, the stumble, or the falls outside over the hose and different things like that. And then for us, the other important one I feel is that it's when they're falling from their own height, okay, there's a lot of falls. But once we add some assistive equipment, so they're in a wheelchair, they're in a lift, they're in a hoist, anything like that, the number of days they're going to spend in hospital and the type of injuries they have are so significantly different. And for us as podiatrists, you know, every day when we put a patient up in our chair, we raise them to ortho height. So if you walk out, they have a hypoglycemic attack and fall off your chair, they're going to break something. Or when we take them up really high and then tilt the chair when we want to do heels or something like that, that's neuro height. So if they fall off, they're going to have a head injury. So it's a similar idea to that assistive equipment. So it's something I never do is walk out and leave my patient up in the air. And that was getting told off by an orthopedic reg at Royal Perth a decade ago. So whenever I leave the room to get something, put your patient down to the lowest level, so they're going to have the least amount of injuries. But again, we're up there with 33% of the injuries to the lower limb. I don't think we see the fractures from the hips and things, but I think we see a lot of the open wounds as well. So diabetes and falls and frailty. Diabetes, so I've got a definition of a fall up the top there, which is, an excluding an intentional change, which is always quite funny, but diabetes causes frailty, and frailty causes falls, and then falls cause frailty, and frailty cause falls. So it's really that I haven't done very well with my arrows there, but there's a lot of risk factors there for our people. Diabetes, the frailty of it, the obesity, the muscle weakness, the cardiovascular disease. Have they already had a heart attack? Have they got cardiomyopathy? And then they're physically inactive. All of these things make them more frail, that muscle weakness, which can lead to falls. So diabetes in itself is potentially, and some other research says as well, that we're looking at diabetes is causing the falls. But then we've got some diabetes-related falls risk factors that I will talk about today, and that's the sensory motor, the muscle weakness. Okay, so we've got the muscle weakness of frailty and the falls relation, the poor postural control and gait changes, retinopathy, hypoglycemia, polypharmacy. I think we're in a really good position to recognise polypharmacy and maybe engage our pharmacists or our doctors or our nurse practitioners more, because as soon as someone's diagnosed with diabetes, they're going to get some diabetes meds. Okay, maybe they'll even get 2 at the beginning, but maybe they get 1. And we're absolutely going to give them blood pressure medication and a lipid drug immediately. So they're already on 3 medications the day that they get diagnosed. Then there's the fact they already were taking thyroxine and something else and something else. So, with a diagnosis, we put them into that polypharmacy. That is a falls risk in itself. So, and when we're lucky, we get a good referral with all the medications on it. And we know sometimes it's half the page. So our patients are at risk the moment they turn up and see us. So neuropathy. So we've got the 3 sorts of neuropathy, hey? So autonomic neuropathy, this we can't test for really easily, but we see it a lot. It's that dry skin, okay? And this is the blood flow and it's an automatic thing, telling the nerves, the skin is a bit dry, turn on and sweat. Oh, it's moist enough now, turn off. This gets damaged quite early in diabetes with neuropathy. Then we've got motor neuropathy. So now I'm going to hopefully let me know if you can't see. So this is Wilma, okay? Wilma's got quite a few things wrong with her, but she's the classic of what is foot deformity that comes from motor neuropathy. Okay?
Yeah, but Deb, I don't think we can see Wilma.
You can't see Wilma?
No, we can still see your slide, neuropathy slide.
Any suggestions, Apu?
We need to see your video, don't we?
Yeah.
Yeah, so change back to...
Yeah, just...
how about if I stop sharing for a moment?
Yeah.
Sorry, guys. Okay, so here's Wilma. Okay. Thanks so much, Karen. So Wilma has foot deformity, okay, from motor neuropathy, and that involves that she's got reduced range of motion, so she doesn't actually have a foot that's at 90 degrees to start with. Okay, she's also got, well, she doesn't, but yeah, they often have reduced range of motion in the first MPJ as well. Then they have these claw toes, okay, so her toes are all clawed up. Sometimes they can, in the beginning, you can stretch them out, but later they become fixed. And they become fixed because there is that muscle weakness and imbalance. So like they spoke earlier, where you can see the hollows in between their tendons. This is the small muscles wasting. So there's an imbalance between the anterior and the posterior muscles. This also, what happens is, there should be a beautiful big fat pad underneath your metatarsals. When those toes claw up, the fat pad moves forward. Okay, so the fat pad's now sitting up here in the air doing nothing, and they're walking on very prominent metatarsal heads. So you often actually feel like it's skin and bone. You can feel their bone. Quite literally it is, okay? So this is your motor neuropathy. Okay, so I'll swap backwards and forwards between screens. So if you can't see, let me know. And then, of course, sensory neuropathy. So this is the loss of protective sensation. The loss of protective sensation, we have to be aware that's really testing the risk of ulceration. And we test that with a monofilament on the plantar surface. But it can also be used to look for diabetic sensory motor polyneuropathy by testing the top of the foot. Okay, so here we go. So yeah, sensory, they're getting burning, tingling, numbness. Everyone will feel something different. Some will feel like they're walking on a cushion of air. Some will feel like their sock is crinkled up. We need to listen to these patients, okay? They're telling us a lot. Autonomic we can't test, and we just saw Wilma. So it is DSPN, so it is diabetic sensory motor peripheral neuropathy, okay? So it's length dependent. It does start at the very tips of the toes. It starts at the very tip of the hallux, okay? And it moves its way up. And it is always in diabetic neuropathy symmetrical. So if they're insensate on their right hallux, they'll be insensate on their left hallux. And if it's not, if it's one-sided, then it's not diabetic neuropathy, and we need to do some other differential diagnoses to work it out. It's always symmetrical. It always starts at the very end, and it's sensory motor. It is the combination of those sensory and the motor nerves. So we've got all these underlying factors. Some of them we absolutely can't change, but some of them can be modified, okay? So their obesity, okay, their hypertension, their smoking, their glycemia, and their lipids. These can all be modified, but how do we most often modify these things is with a medication. So then we're adding straight away to the polypharmacy and adding to their risk possibly. They're not always medication, but it is what can we change. Now, like I said, it starts at the tips of the toes, okay, and it works its way back up the foot. It's really important because that's why we do the testing on the dorsum of the foot. I've often been queried about this and that I, kill the big toe. It's all about the big toe, but it is all about the big toe. It's about finding the neuropathy as soon as we can, because you remember in each digit you've got 4 little nerves, 2 going at the top and 2 on the plantar. We could test the plantar, okay, because we'd get a similar outcome, but we are testing just, those nerves go right to the tip there. So when we're testing on the IPJ, we're catching it as soon as we can, but it does move from there up the foot, okay, and up the leg. And I've certainly had people that are insensate, up into the middle of their thighs. There is this dieback, so it is the axle. It is, the big motors, nerves losing their axial covering, and this glove and stocking distribution. I think I might stop using this term because it's a little bit sexist. And also I said it as a student and I read it, but I never really understood what it meant. Okay, so it partly means, that you wear gloves and you could wear a stocking and it's where you would get it. But it also talks about how it develops, okay, that, back in the old days, ladies used to put their gloves on, they'd actually put little bits on their fingers, get all their little fingers in, and then pull the glove back to get it all the way. So it's about the way that it develops. How are we going to look for it? We're going to screen it and diagnose it with a good patient history, an assessment of the signs and symptoms. Now, small and large nerve damage coexist. It happens at the same time, okay? There's no evidence to suggest it starts with small and goes to the large, or it starts with the large and goes to the small. And, this is my favourite man, one of my favourite men in the world, Bolton, and this is his latest article, and it's telling me the same thing. There's still no good in prospective studies that tell us it's one or the other. You need to test both of them, okay? The other one that I find really important is that test in pre-diabetes as well, because, you know, I have a patient who's been pre-diabetic for, you know, 15 years, and she's neuropathic to the knee, okay, but she doesn't have diabetes, so it's not neuropathy, but she fails every test because she's been pre-diabetic for that long, okay? The damage is happening. It does mean there's times when her sugars are a bit high. So this was a nice study from Germany where it was like, yeah, 28% of diagnosed people with diabetes had neuropathy, but they found 13% with those in impaired glucose and some with impaired fasting. So some of the damage is happening much earlier. So we need to screen as soon as we can. If a patient says, no, I'm just pre-diabetic, then take a little bit of time and do some screening, because you might be able to give them some education now, and you might find they've also got something. So each person is going to be a little bit different with their symptoms, okay? I think the most important thing is to listen to these patients, because they haven't been heard, okay? Or they've complained to the doctor that my feet hurt, or my feet wake me up at night, my feet tingle. It's yeah. Where we actually stop and listen. And I think it's just the greatest thing that we can do, because you listen to them, you hear, they sound like neuropathic symptoms, and then go and do some tests, okay? And then, yeah, a lot of them do have signs of neuropathy, and they feel really relieved to know it's not all in my head, it's actually in my nerves. There's actually something wrong with the feet in my nerves. I'm not going crazy. So they'll all feel something different, and it'll change at different times. And the last little bit that says, you know, whatever works for them, that will also be whatever people do at the time that helps them with their burning or their tingling. I've just been through it with my dad as a result of chemotherapy. He has some really horrible neuropathy, and it doesn't matter that I can assess him and I can give him education. He's not going to listen to me. He's listening to his best mate, who was using a tinea cream. So a tinea cream, mum puts the tinea cream on, and then my socks, and that works, and that's what works for me. He doesn't have tinea, but he believes that works for him. That's what has worked for some time. It doesn't work anymore. He needs to find something else, just to chat with some more mates to get some better ideas. But listen to them, as long as it's not dangerous, you know, support them, because they are having a really hard time often with the symptoms. So the symptoms questionnaires that you can use, there's a lot out there. Bolton's study suggested this first one at the top, the DN4. I'd actually never seen that one. I still like the neuropathy symptom score. Just because it's simple questions, I can run off on my head, I can do the numbers, and I can give them a score. I also like it because, so here's the ND4. It's really quite similar, or you could give it to the patient, but it does require you to do something. Where for me, the symptom score is just some simple questions I run off. Do you get any burning, tingling, or numbness in your feet? Yes, I do, 2 points. Do you get any cramps or any fatigue? Oh yeah, I get cramps at night. Okay, another point. Do you get that in your feet or in your calves or anywhere else? No, I get it in my feet, another 2 points. If they're saying they're getting it in other parts of their bodies, then, you know, that's when we need to investigate further. Is that pain worse at night? Yes, it is, 2 points. Has it ever woken you up from your sleep at night? Yes, it does. And what makes it feel better? I get up and I walk around, 10 points, done. I like this one because it helps me to start my education straight away, because people think neuropathy is worse at night because I've got nothing to think about. So that's when I think of it and it annoys me. No, that's what neuropathy is, okay? Or nerve pain is often worse at night, and it's something that helps us direct us to that. So it lets me educate people. It also flags for me that someone who's got hot burning feet that wake them up and they get up and walk around, or they stand and it makes their feet feel better, then it's really important that you do the vascular assessment, because you need to differentiate, is it peripheral neuropathy or is it rest pain from peripheral arterial disease? So if they say, yeah, I get up and I walk around, I've already done my vascular normally. I do vascular neuro, but if not, make sure you get your hands on, palpate pulses, get your Doppler on, have a listen, and if in doubt, do a toe pressure. Okay, so, and the neuropathy disability score, we used to put them both together, but yeah, it's the symptom score that I really like to show here. Just want to flag with you that when you're reading an article, do check about the community that it's in, because for example, you know, 87% of people having neuropathy in a tertiary multidisciplinary clinic, yeah, totally agree, believe that 100%. But if we're out in a little urban community or in a remote community, I want to know what tests they use to decide that. Okay, so a biothesiometer, you know, really reliable, or which combination of tests did they use to do it, or did they not even state it at all? So always in the methods section, just read how did they diagnose it. We can also notice Bruce here. This is, oh, he was our Fremantle study. Okay, so screening for the signs. We're going to do vibration, ideally with a graduated tuning fork. The position I really like. It's not really strong evidence, but for falls, I find it really important because it is about wiggling the toe and do they feel it up or down? Because that position sense is a reflex, okay? And it's a Golgi reflex. It's the fastest reflex in our body. It doesn't even go to the brain. It just flips up to the spine and back and says, hey, lift that toe. So you and I, if we're walking along and there's a mat, our toe feels that. The message goes, we lift up our toe, we lift up our foot higher. People with diabetes or with neuropathy, that message doesn't get there, and it doesn't get there fast enough, and it's a reason they fall. So the monofilament will do, or the Ipswich touch test. And the monofilament, like I say, we're going to put it to the top of the toe when we're looking for neuropathy. If you're putting it on the bottom of the foot, you're looking for their risk of ulceration. So know what the test is and what you're looking for. And the latest review said it's 4 sites, okay? You've got to test 4 sites on each foot with the monofilament for the risk of ulceration. Ankle reflex is still up there. That's really reliable with inter and intra-rater reliability, and it's easy to do. And then there's the automated devices. I've actually bought one, and I've never really used it because I used it on myself and it really hurt, and it was like, wow. But there are ways that we can get a number and quantitatively get the same number, you, me, next week, an hour later, that we'll get the same number. So your large nerves, we've got quite a few tests. Our small nerves, we've just got the 2 tests. So your pinprick and your hot and cold. Latest review, again, said these aren't really reliable. Yeah, okay. But for me, I've been working the wheat belt for 20 years now, and I've been doing these exact same tests on my same patients for 20 years. So I do them in the same way, in the same position. I do them regularly, and I can actually, you know, document and see a change and then educate people along with the changes. And just a little flag that, yeah, 25% of our people will get some painful neuropathy, which then is straight away, we're going to give them, there's a stepwise of the medications that we should give them. And it starts with their antidepressants, but then we get to pregabalins and your Lyricas, and then a higher dose of Lyrica, and then a higher dose of Lyrica. And these, some people can't get on with them at all. You know, Lyrica will make them just feel too drowsy, and it's too drowsy and doesn't, the benefit of the pain reduction isn't enough for them. Where, for instance, my dad, you know, his Lyrica is going up and up, but he can tolerate it, and he's not falling, and he's not at risk. He feels himself. So yeah, beware, once we start medicating people, we add to their falls risks as well. So the Ipswich touch test is really simple. You quite literally just touch the top of the toes with your finger, okay? They're saying it's for resource poor people, or for instance, if you're walking around a ward, or a community event or something, it is a simple way. The person must close their eyes. You say, this is toe number 1, P1, 2, 3, 4, 5. And then I just realized you can't see I'm doing all these little finger signs. Oh, I'll show you in a moment. This one is just a beautiful, lays it out really simply for us. Okay, so we absolutely start where you want to do, you do a small fiber test. Make sure you do one. Do your vibration. So you're looking at small and large nerves. It's really important. You can then go on and do additional tests. Okay. We're also going to ask about their symptoms. Okay. So use a questionnaire that works for you. Then we come down. It's really important to consider the other causes. There's many other things that cause it. Okay. So Bolton always used to say that diabetic neuropathy is a diagnosis of exclusion. They don't say it as much anymore, but you really want to make sure, because some of these things down here, we can make a really big difference to. Vitamin B12 is a classic example of, get people to have some vitamin B12 shots and their hot burning feet that wake them up at night go away. Okay. So I've just put these ones up so you can share it with everyone, because like I say, I've been criticised for doing all the tests on the hallux, but I know why I've always done the tests on the hallux, because it's distal, symmetrical, sensory motor neuropathy. But yeah, this is what Bolton says. It is from the original articles are pretty old, and then I went and had a look, and it was actually 1992 was the first CD or DVD that I got from the International Working Group, where this is where it came from, where they also said, test these things on the dorsum. It was finding a computer that had a disk drive that was more interesting. And this one again for the sharp blunt and the temperature again is telling me to do it on the dorsal side of the big toe and the foot. Temperature, dorsal side of the foot and the big toe. Wherever you do it the same place every year on every patient, so that you can assess the change in your patient and educate them appropriately. So this is the one that I give students, okay? So you could all have a little go at this later, but these are all the different things that cause neuropathy. So when I'm sitting with my patient and they've given me their symptoms and I've done some testing, then I go through this list of things to make sure it's not something else before I write to the doctor and say, yeah, this is diabetic sensory motor peripheral neuropathy, okay? And this is a really old book that I got it from, and I studied at the end of the 80s, and that was just, it's a list that's ever growing, okay? So just keep remembering that what's on the list, there's more, and every day there'll be more. Because for instance, some of the really early HIV medications cause some really severe peripheral neuropathy. And some of those people are still alive and living with their neuropathy. There's also some of the stomach banding and stomach obesity surgeries. Okay, I had a patient, neuropathic, wound on the end of his toe. He'd been to the multidisciplinary team. None of us could find any reason why this guy had neuropathy. I've been through my mnemonic, asked the doctor to check all blood tests and results. But then, down the track one time, he mentions to me that he used to be a big fat guy, and one day he realized he was fat, and he had, some stomach surgery, and now he's not fat anymore, but he's potentially had some chronic vitamin B12 deficiency over a decade, and maybe that was it. I don't know, but there's something new every day. And of course, these days there's all the chemotherapy, and maybe some of the immunotherapy affects some of the small nerves more than the large nerves. And of course, there's new drugs every day. So I'll stop my screen for a second, and here we go. So just going to show you how I do a diabetic foot assessment for neuropathy. I do it the same way all the time. See how you go. So this is the graduated tuning fork. So I'm just going to pretend and go ahead and do this. Okay, so first thing is, so little Miss Patient, I'm going to do this test. Can I put it on your hand first? So always test it. Can you tell me what feeling it is? What can you feel? Buzzing, zapping, whatever word they use is the one I use. Okay, I'm going to make it zing. I'm going to put it on your toe. It's going to go down less and less. Can you tell me when you can't feel it anymore? Okay, so eyes closed. Always get them to close your eyes. Okay, so you flick it. Okay, you put it on the IPJ, dorsal. Okay, you turn. Make sure you can see it. Okay, I didn't do that well. Sorry. Can you feel it? They say yes. Tell me when it's gone. Now I'm watching these little triangles here form. There's 2 triangles, okay? No, it's not going to show. But now you can see the black ones coming up, okay? And the white ones going down. And when they say it's gone, you tell me what number it is, okay? That wasn't very good. So 4 is normal, okay? And then know that after 75 years of age, their large nerves are reducing anyway. But I like it because I can actually have a number and I'll write it in my notes. Tuning fork out at 6. Next year I do it, tuning fork 6. The following year, tuning fork is 4. Okay, we're starting to get into the range of some pathology. Then it comes down. Other people, you will actually put it on. Can you feel it? They can't feel it. Okay, you'll always be able to feel it through your fingers. I do the hallux, okay, then just out of interest, I then do it on the medial MPJ, I do it on the medial malleoli, okay, and then I do the tibial tuberosity, just because I want to know how far their neuropathy is going up their foot, because it does make a difference when they have those falls and cut their legs, or the rose bushes take something. They don't feel it when the rose bush is taking a chunk out of the back of the leg, but they're bleeding on your bed. Okay, so tuning fork. There's ungraduated ones, and then I'm not so good at them, but you put it on and you ask the patient, and then you just stop it. Hopefully when you stop it, they say it's gone. Okay, I then straight away use the tuning fork as well for hot and cold. Okay, so can I do this one on your hand? I'm going to say this one's cold and this one's not so cold. So once again, the cold and the not so cold. Okay, I'm going to put it on your toe and you tell me which one it is. Eyes closed. Onto the big toe on the dorsum. Is it cold or not so cold? They tell me something. Is it cold or not so cold? Is it cold or not so cold? Go to the other foot. Cold or not so cold? Cold, not so cold, cold or not so cold. Okay, I give them some feedback straight away. So you didn't do very well with that one. You couldn't actually tell the difference between those toes. So then we get on to about some heat education, falling asleep in front of the heater, sitting around a fire, the rubbing of a new shoe that creates a blister. It's hot first. You and I feel the heat and we know and kick our shoe off. They can't feel it and they keep going. Okay, so lots of people say, oh, I can't tell the difference, or it's not a big enough difference. But most people, when you do it on their arm, they can tell the difference. So if they can tell the difference up here, their nerves are working and there's enough temperature change that if they can't feel it on their foot, I believe this test. So the next one is the pinprick. Okay, so this one is the Neuropen. No, he doesn't have a name on it. Okay, what you're going to do, it's got this little bit. Okay, it's got a blunt end and a sharp end. You put it in the Neuropen and you push, it does a little click. Okay, well, there's the name, Neuropen. And what you're going to do is put it onto the foot and you push it until, can you see that little white dot is between the squares? Okay, so it's got to go right in between there. So then it's 40 grams of force. Again, it means I'm giving the same force every year, every week, every patient. So the same thing, say to the patient, this one's a bit nasty, can I do it on your hand? So this one's sharp and this one's not so sharp. So once again, the sharp one and not so sharp. Good. I'm going to press it onto your toe. Can you tell me which one it is? Eyes closed. So same thing with this one. Really, you just do sharp because blunt doesn't tell us anything. Blunt tells us they can feel something, but they can't differentiate. So again, so making sure that you get it. I have it facing me so I can see. Is it sharp or not so sharp? Sharp or not so sharp? Sharp or not so sharp? Okay, so they get a score. You know, if they get it wrong twice, they get it wrong. They failed the test. The other thing is that with patients that you'll put it on and they're going sharp. Well, for me, they fail that test because again, it's a reflex. If you tread on something sharp or it's that protective sensation, you should pull up straight away. So if a patient, I can hold this on here and they're not responding and they're not sure, then that bit of glass has actually gone through their shoe and into their foot and they didn't realize yet. So simple test, not very expensive, nice to do. Then you've got your monofilament. Okay, so the monofilament, I do, this is a very expensive piece of fishing line. I do it on myself first. It bends easily because some people, when you flick it out, they will be shocked and think, oh, that's sharp, that's nasty. Okay, so I always do it on myself first. Okay, and then say, can I do it on your arm? Do it on their arm. It's a light touch. Oh, I can only just feel it. That's right, it is a just feel. Okay, I'm going to press it onto your foot, say yes when you feel it. Okay, so I'm going for the dorsum of the foot, of the IPJ. Ooh. Okay, if they say nothing, you move to the next foot. Okay, so that's when we're looking for diabetic neuropathy, yeah? If you want to use it underneath, absolutely, we do. And you want to use it on 4 spots, and you can't even see that, sorry. And then we're looking for their risk of ulceration, okay? The monofilament, do throw it away after 100 uses. My MMEX, my patient information system, lets me audit how many diabetic assessments I do. So I do have an idea when to throw it away. Otherwise, you need to work that out in your own clinic. But yeah, press it. It needs to bend, okay? It's 10 grams of force. It needs to just buckle a little bit. Don't do it over callus because they won't feel it. And that's a consideration for me, or a problem with it. But also sometimes, you know, you put it on and it slips. Yeah, just do it again. So yeah, your monofilament. Then I always end off with a ankle reflex. I like to do it this way. I just put the foot on force and then I hit my own hand and I get a nice reflex. I like it that way because the patient you don't have to move the patient, and it's often then hard to get a patient to relax. You know, you're trying to put their foot on stretch and they're trying to help you and you're saying, no, relax. Where that way I can just, bam, do it very easily. Learned that one from Ben. But reflexes are something that definitely disappear in our people with diabetes, okay? When I first worked at Royal Perth, I thought I couldn't do a reflex anymore because no one had one. So I did some research and I found 13 different ways to do it, and they still don't have it, okay, because it does disappear. But it is a reliable test that we can do, and as podiatrists, we're really good at it. So go ahead and do it. So yeah, they're the tests. Oh, no, one more, the falls one, of course, sorry. This last one is for proprioception. Again, doesn't have great inter or intra reliability, but it's a really good education tool, and it's finished as a sweep. We do it all, okay? So you wiggle the toe. Maybe if I turn it that way, how do I get you to see? Ooh, no, we can't see it all. Oh. Then you literally just wiggle the toe up and down, and then hold it up or down. Okay, so I'm going to wiggle your toe. I'm going to leave it up or down, and you need to tell me. Now, I always used to wiggle and put it up quite a long way, wiggle, 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 and down. But these days I do some that, you know, is more like a mat, something where it's like just up. Can they tell if it's up or down? Would that reflex, would that protective sensation work for them to recover? Wiggle, 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 and down, up or down. So I do 3 on each foot, okay? And the hip switch touch test, you quite literally just touch their toe like a monofilament, 1 to 1.5 seconds. So you say, this is toe number 1, this is number 2, 3, 4, and 5. I'm going to touch one of your toes and you tell me which one it is. So close your eyes. You know, they say that's not piggy number 4. It's my big one. It's my little one. Oh, it's really hard because remember the nerves bifurcate. So the nerve, one bit goes to toe number 4, but the other bit goes to the medial side of toe number 5. So it is a hard test for them. So do aim for the middle there. Okay, so that's how you do a diabetic neuropathy or peripheral neuropathy assessment. I'll also just share with Apu, I have a PowerPoint that I use with the students where I've literally spelled out word for word what I do and how I say it. Everyone can, it just means that they start from the beginning and then they, you know, what happens when people graduate and start doing things a little bit different, but it's a starting point for how do I actually do this? So a little bit just about gait changes, okay? Because it is really important. It is the foot that's not ready to take the weight, or the foot that's not in the right position at the right time, or the weight is in the wrong place, that they stumble. So yeah, beautiful. Like I said, did some research, a 2022 article. So what they found is yes, it, you know, neuropathy has a negative impact on people's balance, okay? People with diabetes, and neuropathy, you and I, you know, we can stand and stand still, okay? They constantly have got a little bit of a sway going on just to maintain their balance, okay? It has a negative impact on the gait kinematics, yes, and increased risks of falls. So what they did is they included 42 studies, 10 were on falls, 7 were about falls and postural instability. The thing is, of those 10, none were classified as good or very good on the PRISMA guidelines. So they're of low quality. So it's a field that's still got a long way to go as we try to get higher quality studies to actually start to detect when is it, or which bits of gait, or what is really making the big differences. So yeah, there's a more chance that they fall. We need more to get higher quality. We're going to need more multifactorial assessment. So that's going to be our physios, our podiatrists, our gait people, but how about our pharmacists as well? How about our diabetes educators that know a lot more? So we're going to need a larger assessment. We need some random samples that's going to help us, and some prospective trials, because where so many of the trials or studies are asking people about when they fell. So we're asking about the history. So it's a recall bias. What really happened and what they remember happened are quite different. But then there's this beautiful new article as well, is these smart technologies where we've actually prospectively got sensors in people's shoes and seeing when they fall, but also starting to see when the gait changes happen. And what we're finding is it's really early. Okay, so potentially before they've even got any symptoms or any signs of neuropathy, that there's already some changes in their gait happening. So they could tell us there's a correlation, okay, and that it's altered. There's a correlation with the instability and maybe how severe. But with stronger study designs, we're going to be able to get further than just a correlation. But these people, they definitely walk slower. They have an altered gait pattern, and they do have reduced muscle strength and the joint range of motion. And you might already know it. You hear your diabetic patient coming. You hear that as their forefoot slaps the ground, okay? There's quite a few reasons for it, but you hear your diabetic coming, and it is reduced strength, it is reduced torque, and they're just that slow cadence, that slow meandering they have, that's partly for them to maintain their balance. But the other thing is, or it goes back to that, you know, one of those earlier slides about diabetes causes this frailty. So is it actually diabetes itself that's causing the postural control through the poor glycemic control or the neurocognitive functions? You know, is diabetes what's actually doing it? We're going to keep looking further because we're sure we're going to be able to find something, but it's this fallback of, you know, diabetes really affects the whole body. So it's poorly understood, but it's definitely in the very early stages. If you've got people with symptoms and you've got some signs, then they will have some changes to their gait, these sensory motor changes. The compensation is either at the ankle and the hip. They're our first two options. And for our people with diabetes, they already have a reduced range of motion at the ankle. So their ability to compensate is reduced as well. Hence, they might fall more often or harder. And then the hip compensation, that's the other one where we compensate and they've already got some muscle weakness. So they're the first two choices of how to recover from a fall, a slip, a trip, when you're losing your balance. For our people with diabetes, these are already reduced. So this study was, people with diabetes of, you know, less 5 years and more, with or without symptoms, who are already showing changes in their gait. So these are some of the things that you can see will change. So their stride length, so they don't take as big as steps anymore. Okay, they take smaller steps. The velocity, so they walk slower. The stance phase is when you've got 2 feet on the ground. That's when they're most stable, and that's the double support, and that's when they extend this period of time because it's the safest and what they can do. Your swing phase is when you've got one leg in the air. This is their most unstable time, and for many reasons that gets shorter. Okay, they have the center of motion. They've got a whole lot more sway going on. The ankle sway, the hip sway, everything is swaying and moving a lot more. So this is your gait cycle. Okay, so can I find my, I can't find my mouse. Oh, he's gone. Rightio, sorry. So the gait cycle is your 2 steps, okay? And it starts with your heel strike. Ideally for us, it's beautiful. We strike on the lateral side of our heel, the foot's dorsiflexed. It slowly comes down and we load onto that forefoot, so into mid stance. Then we're standing all our weight on one foot. So that's a really difficult thing. Your heel lifts off, okay? So you lift off that heel, that leg next one is going into swing phase. So as it's swinging, the foot has to dorsiflex to be able to lift up and get through before it strikes the ground again. So walking is a series of losses and recovery of balance in a normal gait. Now, I really would like for my mouse to work. It's going to kill me. Okay, so here we go. We are people with diabetes. So this very first 0 degrees, the initial contact, this is where their first problem is, where their first alteration of gait is. Because think back to Wilma. She's got reduced range of motion at her ankle. Her ankle doesn't actually dorsiflex to the 10 degrees or even 5 degrees that's required for her heel strike. So she's already at a loss at 0 degrees there, okay, at the initial contact. Then because her foot is dorsiflexed, it doesn't slowly come down. That's that slap that you hear, okay? The forefoot hits the ground much sooner than it should. And then those poor metatarsal heads, they don't have that nice fat cushioning pad under them anymore. That's slapping onto the bones. Okay, so then they're in mid stance and they've been there a bit too long and longer than they should have been. Then we get to the 30% where heel rise. Well, actually, these people with diabetes, they've got the heel rise happens sooner. It doesn't happen at 30%. It's a bit sooner because they've got this ankle equinus. They don't have enough range of motion in the ankle. The ankle pops up early. So then they're loading onto that forefoot, which has already been injured and had too much pressure on it. And now there's more pressure on it for longer, okay? Then they lift up the foot, okay? Now they're into the swing phase. And again, is this chance of they don't have enough dorsiflexion or toes to actually lift up that foot through it, like the 73% phase there, that maybe the toes are hanging down. Maybe it's the anterior leg muscle weakness. Maybe it's the anterior thigh muscle weakness that they can't actually pick that leg up far enough. The vertical tibia, they, again, don't always get there because of the equinus, and then they come through in the heel. So there's multiple points where a person with diabetes and neuropathy and some motor neuropathy changes doesn't have a normal gait cycle. So you can hear them coming with that foot slap, and their series of loss and recovery of balance is not regular as well. I've got a slide to show you that one. So the other thing is just their vertical displacement, their center of mass. So it's going up and down. So, but when it's highest, that's when in mid stance, when they're standing on one foot and they've got some muscle weakness and they're not that strong, okay? And that's why they want to get that other foot down sooner. So they've got the double support, 2 feet on the ground. And when we look at the side to side, it's at no time is, at that most unstable point at the 30% and at your 80% in your mid stance, that's when you're up high, your body weight's up high or your center of mass, but actually it's out to the side. It's not even directly underneath you. So this one, not underneath you. And of course, this is all just when we've got people with normal feet. And then we start, there's some soft tissue changes. Another way to think about it as well is you've got the glycosylation of the around the joints and the collagen that leads to the stiffening of the structures, that reduced range of motion in the ankle and the first MPJ. You've also got the Achilles tendon actually thickens in our people with diabetes, okay? And it also thickens the plantar fascia. So once the plantar fascia is thickened, the windlass mechanism, which you all know and how it should work, and it pops, it's beautiful. Well, with our people with diabetes, part of that early heel lift is that the windlass mechanism is triggered early, and then it stays on for longer, and that's why they're in that longer stance phase. So just another way to think about it. And it's this conservative gait pattern. They walk slower, they have more time on 2 legs, they don't do bigger steps, and it's all about trying to balance and catch themselves all the time, because that's in a normal gait, and then we start amputating bits. So this is just a photo of someone who's had, one little toe off here on the left foot, but on the right foot, we've taken off a bit of the first ray and a couple more toes. So what we can see here on the left is her center of force, where it's going, that it actually stops in the midfoot, okay? Or this one, on the right, her center of force, okay, the red is high force, the blue is lower force, but it actually stops in the middle of the foot, okay? And the next slide can show us, this is what it's like. This is just 2 steps. And then with people with diabetes, they're never the same, okay? As you can see in the first one on the right there, where the center of force just made it just past the heel, and then push, it was over to the left foot really quite quickly. But it traveled a little bit into the midfoot there, but then, it's flopped over onto the right foot. But it was barely on the right foot for a moment before, it was back to the left foot. So you see the 2 right feet, that their center of mass, their center of force, their trajectory isn't the same every time. That's that loss and recovery of balance that they're doing all the time. That's so very hard for them. So yeah, we have Strideway and some F-scan, and we have some fancy, very expensive equipment at the university where we can actually break it down. And, you know, these aren't big differences here, but every difference is a difference, okay? That they've had to recover their weight or their balance with every single step. So it's also really quite tiring for them, okay? So, of course, going to mention the guidelines, and don't forget they gave you a really nice little toolkit now to have a look at. So there's lots of other testing for falls, and do them if you're confident. There's the timed up and go test. There's the, you know, there's lots of different ones. I don't do them because I'm not confident. I'm not really good at them. I'm also small. So if someone has a fall with a Tonetti test where they have to stand up, turn around and sit down, I'm alone often, so I'm not big enough to get them up, so I'm calling the ambulance, okay? So I use the multi-D teams around me and the health professionals. I work rural and remote, and I'm lucky to have some nurse practitioners. I have the ICDC program with some fantastic nurses. So yeah, use your teams and follow up with our people. So this is what I do. I always ask about falls. You know, have you had a fall in the last year? Ask about what aids they're using. You know, they turn up to me with a silly little walking stick, and I think, you know, is that the best you've got? Oh no, I usually use a walker, but I can't put it in the car, so I don't use it when I come out. Well, they really need to use it when they come out and they're on unfamiliar surfaces. Ask about mats around the home. How many mats have you got? You got a mat at the front door, one at the toilet, one at the back? How many? Is there someone home when they shower? Do they have a personal alarm if they do fall? This is really important for us out in the bush because we have lots of trouble with the alarms. They don't work with every phone provider, or on the farm. You know, I don't get reception in my house, or I have to stand on one leg to get it. So this is important for us to know. Asking if they can get up if they fall, because there's also some great resources that show people, and we teach people how to get up off the floor. So the things that I do is I absolutely do neuropathy assessments. I do them regularly. I love it that my patients, you know, I pull out the monofilament and they just close their eyes. They know what's coming. I pull out the tuning fork and they're, oh, the buzzing thing again. Yes, I do it again and again, and I write it down and I compare it. It's important. But mainly the most important thing is the symptoms and the signs. Let us give the education they need. Because if they've got painful neuropathy, we're going to potentially be medicating them. But if not, there's no intervention for neuropathy. It is about education. My patients get really bored with me. I know, because I talk about it all the time, but I can put up with that, yeah, as long as they keep coming back. And do check their footwear, okay, especially as we change from summer to winter and they pull out their old shoes, and actually, you know, the shoes last year had a hole in them, so they are a falls risk, or they're coming away at the soles. The other one I do is I really nag my patients to use aids, okay? You know, you've got that other really good walking stick with the 4 little prongs on it. That one's much better. You look much safer. Why don't you use that one? I'd really love it if every time you came to see me, you were using your walking stick. Why don't we see if the OT can get you a lighter wheelie walker that you could get in your car? Nagging, I do it well. The other thing is I write to my GPs. I refer on, definitely. Just heard a great story today about someone I referred on for 3 falls in a short time, and some good multi-D care. And these days we can also contact their home care providers. There's lots of assistance and home care packages, and these people are the ones that are at home. They're the ones that are there when they have a shower. They're the ones that can tell me, yeah, I threw away all the mats and then I went back yesterday and they put all the mats back again. So that's what we do. And there's some references. Thanks so much for listening. Really appreciate your time. Don't ever hesitate to contact me if you need some more info.
Thank you so much, Deb. That was very interesting. We have a couple of questions already, and I know we're out of time at the moment, so I'll just quickly go over them. So for Deb, while you're here, I have a question for you. So with the tuning fork, if the patient can feel the vibration and the number shows 4, meaning normal, do you continue to do the other parts, or usually do you do, sorry, wait,
Yeah. Or I do some more.
yeah,
I
or do you,
often,
do you just does not feel, if you, do you still keep going if the person does not feel it, pretty much?
at 4, I would keep going, because for me it's partly interesting because they will be 4 at the hallux, but probably 6 at the medial, first MPJ, then 8. So I can actually see the progression or know where they've got full sensation. But mostly I keep going when they can't feel it at the hallux. Then can they feel it? Then I'll push on. But 4, I do it out of interest.
Yeah, it was really interesting when you showed the different ways how you screen with the models. I love it. It was very interesting to see that. Christine, there is a question for you. Is Pronto sand solution good for diabetes foot ulcers?
I'm going to be honest, it's not something I've heard of, and it's not something that we would routinely use or recommend. I'm not sure if Deb's come across it in her practice at all.
So yeah, Protosan absolutely is used. So they believe it works on the where's just gone? The biofilm. Yeah, on the biofilm. Okay, so often, yeah, it's the first thing to debride a wound, and then put the Protosan on and leave it, and it dries a little bit. Yeah, it's another cleansing product. So mostly you use it in the hospitals on wounds or in the community with wounds.
Thanks, Deb.
You're welcome.
And yeah, I think that was it for questions. All of the resources will be shared with everyone who has registered for this webinar. So rest assured you'll be forwarded on all the resources that were mentioned. And for CPD points, you can just let us know if you're interested in gaining that, and we can help you out with that as well. I'll just go ahead and share my screen again. Can't seem to find it though. So thank you, Christine and Deb. That was a really interesting presentation, and it was just a really great webinar, I feel. So we have some upcoming trainings as well, just to wrap it up, and I know it's a bit late in the night for everyone. We do have a training tomorrow. It's an online workshop on elder abuse recognition and response in older adults. If you work with older people in the aged care sector, that might be of interest to you. So just head on to our website and register if you wanted. It is tomorrow at 10 o'clock. We also have a online workshop training on motivational interviewing in falls prevention. So that is coming up on the 5th of May. And we also have vision and falls prevention among older adults, and that is in partnership with Vision Australia WA. So if you're interested in any of these that are falls prevention focused and older adults focused, head on to our website on the events tab and register to any of them. And we're currently in our Remove Hazards campaign. So that runs from the 1st of March to the 30th of May. The Remove Hazards campaign aims to educate older adults and health and community workers on important information around removing potential hazards and creating safe environments. So we have a campaign toolkit for health professionals to download any resources or social media posts and images. So please download that and use that for in your practice. And so keep the conversation from today going. We have a Community Falls network. It's a network that meets quarterly to provide professionals such as yourselves tuning in today, working in the falls prevention space, to connect with other people and share learnings and solutions in falls prevention. I highly recommend joining that, and email me if you're interested in joining. We have our next meeting sometime in May. So yeah, that, and Connected, which is a networking program that we have worked on. So We Connected is a online networking program that you can sign up for. And if you're a health professional, you'll be paired with another random health professional in the injury prevention space. So it's a great way to network. And if you want to read and sign up, there's a QR code on your screen there. Also, when you close this webinar, there will be a survey that pops up, and we'd love to hear your feedback. So if you could just complete that survey and let us know what you thought about today's webinar training, as well as any feedback on future ones, that would be amazing. And that is it for me and for all of us. Thank you so much, and have a safe night. Thanks, everyone. Thanks, Deb.
Bye.